Good afternoon, everyone, and a very warm welcome to today's JMitra Scientific Webinar. On behalf of JMitra and Company Private Limited, thank you for taking the time out of your clinical and laboratory schedules to join us. Well, cervical cancer continues to be one of the leading causes of cancer-related mortality among women in India today. And yet, it remains amongst the most preventable of cancers. The difference between an advanced diagnosis and a curable lesion very often comes down to the quality of screening, how the sample is collected, how it is fixed and stained, and how carefully it is interpreted and reported. Despite the availability of newer technologies, the conventional pap smear remains the backbone of cervical cancer screening in most of our laboratories, which makes getting the fundamentals right more important than ever. Well, today's session, pap smear, best practices for cervical cancer screening and early detection, will take us through exactly these practical aspects. It is my privilege to introduce our distinguished speaker, Dr. Swapnil from EVA Path Lab. Her expertise in cytopathology and diagnostic reporting makes her ideally placed to guide us through this subject. Well, less about me, more about Dr. Swapnil. Over to you, ma'am.
Thank you so much, sir, for the introduction. Now, I think we shall begin with the lecture. Good afternoon, everybody. Very warm welcome. Thank you so much, sir, for inviting me. So today we'll be discussing about pap smear, its importance for cervical cancer screening and early detection. Next slide, please. So, what is the role of pap smear in cervical? Next, please. Before answering that question, we should know when to take pap smear. This is just a very basic question which all of you must be using in your clinical practice. But sometimes when you receive the slides, they are not, they are obscured or by the mucus, or the timing at the time at which the sample is being taken, that is not right. So these points should be just revised. So best time to do smear is mid-cycle, that is 8th to 12th day. Patient should not have any sexual intercourse or should not put anything into the vagina for 24 hours before pap sample, because it can obscure the quality smear. Contraindications are in case of evidence of acute infections and presence of excessive bleeding. So we should avoid doing pap smear at that time because we'll not be able to get the quality material. Next, please. Now, the question is how to perform pap smear. Next, please. So procedure, as you all know, it's a very simple procedure. Just I'll go through that in brief. We should take the consent of the patient and should explain the procedure. Brief history regarding any hormone therapy or previous abnormal smear or any treatment that patient has taken. This should be asked. So now for the proper positioning of the patient should be done. Cervix should be clearly visualized. No chemical should be used to clean the vagina. In case if you are not able to insert the speculum, lubricant can be used, but it should be used with caution and care. And in case of excessive bleeding, as I have earlier told, sometimes a patient is menstruating and we get pap smear. So in that case, we should ask the patient to remove excessive blood and to just flush it out so that we can try to take smear and maintain its quality. While taking the smear with endo brush or spatula, it should be rotated by 360 degree in single direction. Next, please. So how often we need to do pap smear? That's a very important question, and most of our general public, I think they don't know when to get pap smear done. So under 21 year of age, we do not recommend pap smear or HPV screening. Females that are of age 21 to 29 year, we recommend every 3 yearly pap smear. So if pap smear results are negative and nothing is being detected, it's just a routine screening, then HPV testing is not recommended. But if pap smear results show any ASCUS, matlab any atypical lesion, or undetermined lesion, precancerous condition, then we should go for HPV testing. For 30 to 65 years, it is recommended to do co-testing, which includes pap smear as well as HPV testing, which can be done after every 5 years. Now the HPV genotyping, that should be done in patients if HPV test is positive. So even though your pap smear is negative, it is not showing any atypical cells, but when HPV testing is done, you find out there are HPV positive stains, then HPV genotyping should be done to find out the exact stain. So over strains, to find out the exact strains. Over 65 years of age, we generally do not recommend pap smear. Condition, the patient had adequate prior negative screening test. So there is no history, no family history, all the previous pap smear results are negative. Then we can say that you can discontinue pap smear. Next slide, please. So what are how do we prepare the slide? First is spreading of the smear and fixing of the smear. So with the conventional smear, as I have earlier told you, we use that endocervical brush or spatula. So after preparing the smear, generally what we can see that these spatula, because of the spatula mark, you can see the smear prepared is uneven. The smear, the cells are not evenly distributed. So because of that, it could lead to a poor quality smear that could lead to loss of the sample, and will not be able to diagnose some precancerous condition, or in case if cells are very less, then we'll not be able to diagnose it. Regarding the fixation, it should be fixed as soon as the smear is prepared. That is, after preparing the smear, it should be fixed with 95% ethyl alcohol. You can get it privately as a keep it for like 20 to 30 minutes into that, and after that we can go for the staining. Next slide, please. Now, how should the slide be sent to the lab? That's a very, it's a very important topic, because generally when I was doing my PG, we used to get a lot of conventional smears, and it's the same point because they are not properly fixed and the smears were wrapped with the tissue paper. So sometimes when the material is liquid, it's not dried yet, the tissue paper will get stuck to it. So this will also create a major issue while reporting the conventional smear. So especially while you are preparing conventional smear, it should be fixed immediately with a fixative, which could be ethyl alcohol, or in some cases we can also use methanol. And then after that, after the fixation, it should be sent to the lab. So the most important problem with the conventional smear, what we can see is, because we are using that endocervical brush or spatula, because of that only 20% of the sample is get transferred to the slide. So we generally lose around 80% of the cell. That will lead to obviously false negative reporting. Will not able to identify if there is any cancerous cell or any infection or any atypia. So because of that, today we are preferring liquid based cytology. Next slide, please. So what are the limitations of conventional pap smear? Next slide, please. So these are the problems with conventional smear. As I have earlier told you, the smear prepared, it's not evenly distributed. It's a very large area to screen, and moreover the diagnostic cells are scanty, uneven thick areas, drying artifact are very common, obscuring elements mainly blood, mucus, inflammation, these are very oftenly seen, and they can definitely obscure your quality material. So high unsatisfactory rate, high false negative rate, as I have told you, because of the obscuring material, we are not able to detect some of the precancerous conditions, or if few cells are there, we are not able to detect it. This will lead to high false negative rate. Next slide, please. So high false negativity is due to many correctable simple problems. It could be because of sampling error, interpretation error, or fixation is not done properly, or screening error by the cytopathologist. So all these problems can be outcome, or we can outcome all these problems with the help of LBC. Next slide, please. So same that we have discussed earlier, sensitivity of pap smear can be improved if we training to perform pap smear is given to the staff as well, experienced cytopathologist. Repeat the smear in case of menstrual blood or in case of excessive inflammation, and then we should go for LBC. Next slide, please. The solution is LBC. What we can do, why LBC is better than conventional, because we have been using conventional since so much time, and I think in civil hospitals I think we are still using conventional smears. So in LBC, 100% cell retrieval from the device. There is no need for manual smear preparation and fixation. So all the points that are related to manual preparation will not be required. And the slide prepared by LBC show monolayered preparation, well fixed, well stained and well preserved cells. Next slide, please. So what are the other uses of LBC apart from the smear preparation? As we know, if we use it in conventional smear, or the material that we have taken on the slide is dried out, so we cannot use it for molecular, for HPV testing, or for cell block preparation, or for any cervical other immunochemistry if we want to get done. So these are the advantages with LBC, as the material is preserved in a liquid media, so it can be used for other things as well. Next slide, please. So what are the advantages? I think we have discussed the advantages. And what are the disadvantages of LBC? First advantages, just to go through them: reduced inadequate cells, inadequate rates, as cells are better preserved, well fixed and not obscured by blood, mucus and inflammation. Screening time is fast, because area we have to screen is a smaller area with fewer artifacts and clear background. Multiple slides definitely can be prepared because we have ample amount of sample. Cell block can be done. So it can be used for other tests, as I have told earlier, for HPV screening, molecular testing, chlamydia, gonorrhea, or even for cell block preparation. Few disadvantages that we see is more costly than conventional smear. I think that's the major drawback with LBC, because most of our patients are from poor background. They are not ready to pay that much. So it is not that much cost effective for them. Processing definitely can take a lot longer time and requires training for technician and cytopathologist. Next slide, please. This is the slide that we have discussed earlier also. This is just to show you how do we collect sample in LBC. And this is the media in which first we take the sample and then we remove the brush and then we put it inside the media and we just shake it for about 3 to 6 weeks at room temperature. So it allows us more time so that we can do further investigations if required or asked by the clinician. Next slide, please. So these are the limitations of conventional smear as compared to liquid base. The smear prepared in liquid base is uniformed, cells are well preserved, background is clearer. In conventional smears, the cells are uneven, they are thick or thin, obscured by blood, mucus, inflammation. And the number of cells, now will go towards the adequacy criteria. Adequacy criteria for PAP is different in conventional as well as in LBC. In conventional smears, we need to see around 8,000 to 12,000 well-preserved squamous cells, whereas in LBC, we just need 5,000 well-preserved cells. Next slide. So these are some morphological alterations that we can see in LBC. Generally, we are used to see conventional smear. So the morphological alteration should be known just in case to prevent any overdiagnosis. Minimal obscuring material, as I have earlier told you. In case of tumor, especially in case of squamous cell carcinoma, where we can see tumor diathesis, that is necrotic background, much cells, neutrophils, mucus. So all these features are not very clearly seen in LBC because it makes the background clear. So this is kind of a little bit of disadvantage of LBC, and actually we have to get our eye accustomed according to the preparation. So infectious organisms but are better preserved. Cell groups often disrupted, single and dispersed, whereas in case of conventional smear, they are just in chunks or it could be arranged in sheets. An important effect that we have to see in LBC is cell looks smaller due to rounding up effect of liquid that leads to altered NC ratio. So this is the point where we should look for cells, the normal nucleus of the cell. If it is normal, it's not showing, because rounding up of cells may cause or may give you false appearance of eschus or any atypical cell because of falsely increased NC ratio. But as we look at the nucleus is more vesicular, nuclear membrane is well visualized, so we can clearly see the nucleus, its nucleoli, its chromatin. So in that case, it is LBC is better than conventional smear. So caution, initial increase in borderline cases, rounding up effect of the cells, and obviously it's a learning curve. You have to get your eye accustomed to LBC preparation. Next slide, please. So how do we report? So it's according to Bethesda System 2014. So what is the adequacy criteria? For conventional pap smear, we require around 8,000 to 12,000 well preserved and well visualized cells, and for LBC we require just cells. Now about endocervical cells. So yes, endocervical cells are very important. It should be visible, but it is not in the adequacy criteria according to Bethesda 2014. So if you see endocervical cells, then you should mention it, and if it is not there, then we can mention it is absent, but it is not the adequacy criteria. We cannot reject the sample in case of absence of endocervical cells. So what is the minimum amount of cells that we should see? These are around 10 well preserved cells arranged in group and singly. Next slide, please. So this I have already discussed, the specimen adequacy criteria for conventional and liquid base. Next slide, please. Okay, so what are unsatisfactory smear? When do we say that we cannot repair, or you're often gonna see the report saying that it is some squamous cells are visible, but it is obscured by blood, or it is limited by blood or mucus or inflammation, and we need to repeat the pap smear after control of bleeding or after control of inflammation. So these are the factors. First is excessive drying artifact, which is most common problem, because if we do not fix the smear at the same time at the spot, then it will lead to drying artifacts. Excessive blood and pus, which can obscure the cellular details. Scant material, because only 20% of the material will be able to transfer on the slide. So this can lead to definitely no positive results, and it will not help you basically. It will not help clinician to find out the exact picture. Artifacts, conflicts due to trapping of air under cover slip, generally after preparation of the smear and after staining, when we do the mounting. So just in case if air got trapped while doing the mounting, then we can get these conflicts. Contaminant, any kind of contamination, degenerated sperms or histiocytes or any inflammation or fungal spores or maybe glove powder, anything can definitely affect the quality of the smear. Next slide, please. So this is the general categorization of Bethesda 2014. So first, negative for intraepithelial lesion or malignancy, and second we'll be seeing epithelial cell abnormalities. Next slide, please. So non-neoplastic findings, that is negative for intraepithelial lesion or malignancy, we can see these changes. Now why we are discussing these changes? Because today we have decided to discuss about cancer, because sometimes these changes can be confused with the precancerous condition. So first, non-neoplastic cellular variation is the squamous metaplasia. I'll be going through each one of them. So first is the squamous metaplasia. Second is keratotic changes. Third is tubal metaplasia, atrophic smears, and pregnancy associated changes. So these are the cellular variations that we can see. Now moving towards the reactive cellular changes that could be associated with infection, that can lead to typical repair or radiation or cervicitis or IUCD insertion. And then lastly, glandular cell status post-hysterectomy. Next slide, please. So these are the organisms that we can see. These are the common organisms. Trichomonas, fungal organisms generally involve candida, bacterial vaginosis or actinomycotic colony, and cellular changes that can be associated with HSV or cytomegalovirus, and changes associated with HPV. So this is the epithelial cell abnormality nomenclature. Squamous cell, first we'll be discussing about SCUS, that is atypical squamous cells of undetermined significance. Second is cannot exclude HSIL, that is SH. Then low grade squamous intraepithelial lesion, that is LSIL. High grade squamous intraepithelial lesion, that is HSIL, and then carcinoma. So these are the squamous cell abnormalities. Secondly, we can see glandular cell abnormalities. It could be atypia, it could be adenocarcinoma in situ, or it could be invasive adenocarcinoma or any other malignant neoplasm. Next, please. This is just a brief regarding glandular cells atypia. Atypical glandular cells could be endocervical cells or endometrial cells or glandular cells of no special type. Atypical endocervical cells that favor neoplastic etiology. Atypical glandular cells that favor neoplastic etiology. And then endocervical adenocarcinoma in situ or could be adenocarcinoma. So these are the glandular cell atypia, glandular cell abnormalities that we can see while studying a pap smear. Next, please. So before studying the pap smear and looking to its cells, we should know that what is the basic anatomy of female reproductive system and basically from where we are taking the sample. So this, as you can see, this is the cervical region, and this is the exposed part, that is the ectocervix, and this is the endocervix, and this is basically the transformation zone. So when we are taking sample, we should make sure, although it's not in the adequacy criteria, that we should get sample from the transformation zone, as this zone is susceptible to malignancy, to dysplasia, and to neoplastic changes, as these cells of the endocervical cervix, that is columnar cells, are repeatedly changing into squamous type. So cells from this area, transformation zone, is important, and we should try to take these cells while taking the smear. Next slide, please. So these are the basic cells. I just want to show you how these cells look, the normal cells, so that we'll be able to differentiate it from the atypical cells and their mimics. So if we go for squamous epithelial cells, we generally see 4 types of squamous epithelial cells. First is the superficial, intermediate, parabasal, and basal. So these are depending on the age as well and hormone related changes. Second, we'll be seeing endocervical cells, that is from the, as I have told you, endocervix, columnar cells. Third, we'll be seeing bacterial flora. Fourth, if is there any inflammatory cell changes, and fifth is endometrial cells. So that's a very important thing to note. Do we see endometrial cells on smear? Is it normal to see endometrial cells on pap smear? And till when you can say that if you see endometrial cells on smear, it's fine, and after that it should not be there, and we have to report it. Next slide, please. So this is just a picture describing these are the immature cells. As you can see, these are the basal cells, parabasal cells, and as they move towards maturity, their cytoplasm increases, their nucleus size decreases, nucleus become pycnotic, and you can see the change in the type of the cell. See the structure, it is more round and small, and here it is more it's more spread out. The cytoplasm is lighter, and nucleus, you can see this is centrally placed nucleus. This is smaller in case of superficial cells, whereas it's comparatively it is larger in case of immature cells. Next slide, please. So this is the changes during maturation of squamous epithelium. As I have told you, cell size increases, amount of cytoplasm increases, cell shape changes from round oval to polygonal, Texture of cytoplasm changes from dense, thin to transparent, as we have seen in earlier slide. Now regarding nucleus also changes from vesicular to being pycnotic. Pycnotic means it's very small in size. So I've shown you that pycnotic nucleus. And if it is normal in size, clear, then we can see vesicular nucleus, because we'll be able to see what is inside the nucleus, how it's chromatin, how nucleus is placed. And nuclear size decreases. Nucleoli disappears, and the long axis of the nucleus changes from being perpendicular to the basement membrane to the parallel to the base membrane. Can you please show the previous slide so that I can explain this point? So see, you can see nucleus here, it is perpendicular to the basement membrane. So as the nucleus size, as it goes towards maturity and nucleus size decreases, it's likely parallel to the basement membrane. So size is decreased, cells are more elongated, cytoplasm is more, they are polygonal as compared to round oval cells of the basal or immature cells. Next please. Next please. So it's just a brief review regarding normal cells. What are superficial squamous cells? I have told you. These are the superficial squamous cells. They are large, have increased amount of cytoplasm, small pycnotic nucleus, and watery, thin, transparent cytoplasm, which stains generally pink, green, or orange. And then nucleus is pycnotic. See, this is very small, and you can sometimes see perinuclear halo. So it's basically this nucleus followed by a clear zone, so that is called as perinuclear halo. Next slide please. Now, intermediate squamous cell. Why intermediate squamous cells are very important in case of reporting of pap smear? Because this is our referral point. Whatever we are going to compare, whether it's atypical, it is escus or low grade lesion or high grade lesion or squamous cell carcinoma, everything that is we are going to compare it with the nuclear size of the intermediate squamous cell. So these are also polygonal cells. Cytoplasm is thin, transparent, and blue. Nucleus, you can see it's round, oval, centrally placed. It is vesicular, as we have seen in the superficial. It is pycnotic and very small. In this, it is vesicular, but we have to look into the nuclear details as well, the chromatin distribution and the nuclear contour. So it is vesicular, chromatin is fine, granular, it is evenly distributed. As you can see, the chromatin is evenly distributed, and there is no nuclear membrane irregularity. As you can see, you can follow it with the help of a cursor. The line the nucleus shows, it's not showing any irregularity, it is smooth. So these are the features that we should be knowing if we have to compare with atypical cells. Next please. Now the parabasal cells. These are medium-sized round to oval cells. These are the parabasal cells. Cytoplasm is moderately dense. It generally stains blue and green or gray. May contain glycogen, which can lead to see this perinuclear halo. Now moving towards the nucleus, definitely it is bigger as compared to our superficial or intermediate squamous cell, but still it is fine, granular, and chromatin is evenly distributed. So this is the key point that we have to look while looking for or differentiating atypical cells from normal cells. Next slide please. Now moving towards basal cells, rarely seen in pap smear, it is generally seen in case of severe atrophy. They are very small undifferentiated cells. As you can see, they are very small, nucleus is centrally placed, vesicular, round and oval, and cytoplasm. Cytoplasm is basically, as you have seen, this light blue part. So it is well defined, but then you can see cytoplasm is very scanty. It is very less. Next slide please. So moving, these were the squamous epithelial cells. Then we'll see about what are the normal morphology of endocervical cells. How do endocervical cells look? So these are basically columnar cells, tall columnar cells. They are finely vacuolated, can be mucus filled. Cytoplasm is delicate. So you can see two common presentation of endocervical cells while looking the pap smear. First is the honeycomb-like representation. As you can see, all the cells are stacked to each other and their cell borders are well defined. And this is the picket fence palisade or picket fence appearance that we say, because of the nucleus is appearing to be eccentric, and the cytoplasm, all the cytoplasm are attached parallel to each other, and it is elongated. So it is giving a picket fence appearance. Next slide, please. So as I have told you about endometrial cells, we generally don't get to see endometrial cells while reporting PAP, but just in case if we do see endometrial cells, so should we report it as abnormality, or should we look into the stage of the cycle or the duration or which day the patient is on, about her menstrual cycle history, or what we should do. So it is basically these, you can see endometrial cells as small stacked cells, epithelial cells with stroma as well. They can be seen as the fragment or could be seen as the exodus ball. So this central part is the stroma, which is darkly stained, and these are this periphery of lighter stain shows epithelial cells, small epithelial cells that are compactly arranged. So in cycling women, these are expected to be there if we take the pap smear from first day till 12th day. So I know I have already mentioned that you should take pap smear generally in mid-cycle, that is 8th to 12th day, but it is expected to see endometrial cells, and if you see some of the endometrial cells during that time, then you need not to report it or mention it to the clinician. But after 12th day, when the menses have stopped, and still if you are seeing these endometrial cells, then you should mention, or you should take the history and should mention in your report. Next slide, please. So these are the exfoliated endometrial cells, and why we are seeing these exfoliated endometrial cells, because sometimes, because as these cells are small, you can see these also very small cells with centrally placed nucleus, a scant amount of cytoplasm, and they appear to have high NC ratio. So these are the cells which can be confused with high grade squamous epithelial lesion. So it is important to take the history of the patient. We are taking pap smear on which day of the cycle, is it expected to have endometrial cells? If these are exfoliated endometrial cells only, is there any history of previous history of any positive lesion or any smeared abnormal lesion that she has undergone, or any HPV positive findings? So these cells should not be confused with the HSIL, high grade squamous epithelial lesion cells. Next slide, please. Now, moving towards squamous metaplasia, why we are discussing this? Because squamous metaplastic cells can again be confused with SCUS. So it is important to differentiate, because squamous metaplasia is a normal physiological. If we see SCUS, that is a pathological condition. So what are the factors that can lead to squamous metaplasia? Change in pH, any hormonal issues, trauma, inflammation, and definitely, as I have told you, continued replacement of columnar cells by squamous epithelial cells in adult at the transformation zone. Next slide. So, why we have to see the cytology of squamous metaplastic cells? Because these squamous metaplastic cells sometimes can be confused atypical cell. So how you be able to differentiate it from atypical cells? Because they are small, they have dense basophilic cytoplasm, and when we look into the nuclear details, you can see nucleus is although enlarged, relatively high, but the distributed. The cell membrane is almost irregular. It is not showing any irregularity. It is smooth and regular, centrally placed vascular, and it is finely granular. So these are the things that we should keep in mind, because squamous metaplastic cells are the cells that we generally see taking a pap smear, because it could be because of the change in hormone levels or pH, or naturally it can be there. So we need not to confuse cells with SCUS or any atypical cells. One important feature that we can see, it is called as the cytoplasmic processes cells. So these are the spider processes that we can see in squamous metaplastic cells. Next, please. Next slide, please. Back, please. Previous slide, please. So, Next to this, this only. Thank you. Variation in squamous cell, that is anucleate squams. These are the just you can see. Hyperkeratosis is basically it's a response in case of uterine prolapse because of the squamous epithelium is undergoing chronic mucosal irritation. So it can lead to keratinization of the normal squamous epithelium, and it can also lead to loss of nucleus. So these cells, they are generally associated with estrogen effects or can be present in case of inflammation, or if a patient is taking any radiation therapy or chemotherapy, so or in case of uterine prolapse. So if these cells are present, then present in a large amount of quantity, then we need to mention it. But if history is suspected of all the causes, then we need not to mention. Next slide. Now parakeratosis. This is important. Why we are discussing parakeratosis? It is generally abnormal keratinization of the nucleated squamous cells. So in case of it is basically retention of the nucleus. So why the retention of the nucleus? It can be normal, it can be because of infection, or it could be because of cancer. So if in these cells, if the back to the same point, if the nuclear contour, if the nuclear size, if the chromatin distribution, NC ratio, everything is just normal, and you are seeing infection, it could be associated with trichomonal infection or candida infection, then we can consider it as a benign change. But if the nuclear size is high and the chromatin is not evenly distributed, irregular membrane, so these are the features that we should suspect about atypical parakeratosis that can be seen in ESCAS. Next slide, please. Now, moving towards perinuclear halo. As I have told you earlier also, what is perinuclear halo? So that's the centrally placed nucleus. If there is a clearing zone, you can see this clearing zone around the nucleus. This clearing zone is called as perinuclear halo. So it can be seen in multiple cases. Why do we have to look into perinuclear halo? Because perinuclear halo is most commonly seen in HPV, that is human papilloma virus. So it is very important to differentiate this perinuclear halo, which is seen in HPV, to that of pseudo halos. Matlab, it could be seen in because of squamous cells, as I have told you, superficial, because of pycnosis of nucleus. Nucleus is smaller in size, or could be seen in intermediate cells because of glycogen deposition, or could be seen in parabasal cells because of glycogen deposition, or could be seen in immature metaplastic cells. So we should not confuse these features with the true halo, because if we find true halo, we should look for HPV. We should look for cytopathic changes and for HPV, and we should look for nuclear changes and the cell size changes to rule out if there is any LCIL. And then in case of true halo, we should get that HPV testing done, or molecular or genotyping done. Next slide, please. So this is also a benign change which can be confused with malignancy. So this is tubal metaplasia. What is tubal metaplasia? It's basically a benign condition where cervical lining changes to that of fallopian tube. The fallopian tube lining, that what we can see in the cervical lining. Generally, its lining is squamous or columnar, so it gets changed to fallopian tube lining. So it can occur normally also after trauma or childbirth. But as you can see, there are pseudo stratification. So because of this pseudo stratification, these cells can be confused in case of adenocarcinoma because of this stratification. If they are arranged compactly back to back, and because of this pseudo stratification, they can be confused. So how we can rule it out? It is, you can see the presence of cilia. Cilia is there. These fine projections, you can see cytoplasmic projections, and then this is called as terminal bar, if you can see it. So these are the features favoring that it could be because of tubal metaplasia, and we should not look for any cancer. Next slide, please. So atrophy is very important smear, because in atrophic smear what we generally see are the parabasal and basal cells. We do not get to see any superficial or intermediate cells, although it depends on the stage of atrophy. But generally what we see in atrophic smears, that is in post-menopause women is parabasal and basal cells, and as we have discussed, obviously their size is high, their NC ratio is high, or followed by inflammation. If there is atrophic vaginitis or if there is surrounding inflammation, it can show reactive changes as well. So these changes should not be confused with any atypical cells. So it's important to differentiate atrophy or reactive changes associated with atrophy with any atypical cells. Next slide, please. So these are the smears, and why we are seeing it, because you can see cells are smaller in size. Although nucleus is well preserved, contour is maintained, but still cells are very smaller in size. The dense inflammation is there, and there are features called as debris, which is called as granular diathesis. As I have told you earlier, in case of squamous cell carcinoma, we do see tumor diathesis. So it is important here that we should not confuse the features of tumor diathesis or invasive squamous cell carcinoma with that of atrophy showing reactive change with granular diathesis. So it's very important to differentiate between these two. Next slide, please. So these are the cells, as I have told you earlier. Why we are discussing these cells? These cells are the basic intermediate squamous cells with glycogen stored in it, and these can be seen in pregnancy. Or why we have to look for these cells? Because they also have this perinuclear haloing. So these perinuclear clear zone, it should not be confused with the coilocytic change that we see in HPV. So it should not be falsely reported as coilocytic change associated with HPV or cytopathic change associated with HPV. So to confirm that this is not exactly the HPV change, first we have to look into the halo, and then in glycogenated intermediate cells, as you can see, there is a brownish yellowish appearance that can be seen on the microscope. So this we have to see before reporting it to the HPV infection. Next slide, please. Now, reactive squamous cells, as I have told you, either in case of atrophy or in case of infection, dense infection, you can see benign looking nuclear squamous cells with nuclear enlargement. But this is important to note, even though there is nuclear enlargement, the chromatin is evenly distributed, and membrane, the contour will be maintained. These cells, especially when you are dealing with postmenopausal women, often present with mild spotting, could be there, reddish discharge, dense inflammation, parabasal cells, atrophic vaginitis cases. You should not confuse these cells or reactive cells with the atypical cells. Next slide, please. Next slide, please. So IUCD associated changes, again IUCD can lead to changes. It can change the normal epithelial lining, it can lead to vacuolation of the cytoplasm, it can lead to multinucleation. These multinucleations should not be confused, because in LCL cases also, that is low grade epithelial lesion, we do see, or in SCUS as well, we do see multinucleation. So these multinucleations should not be confused with the atypical cells. So it's important to see, if you need to take the history, if IUCD is inserted in the patient, so you need to take history so that you will be able to differentiate it and not falsely diagnose it as atypical cells. Next slide, please. So these are the changes that I have told you. Radiation changes, patient undergoing radiation, they can also see cytomegaly. Cytomegaly means increase in the cytoplasm, show cytoplasmic vacuolation, can show multinucleation. In fact, nucleomegaly, that is increase in the size of nucleus, can be there. So these changes should not also be confused with the atypical cells. Next slide, please. So moving towards the atypical cells that we have been discussing throughout. So first is the atypical squamous cells. Earlier it was generally atypical squamous cells, and now after in Bethesda 2014 they have divided that atypical squamous cell category into two, that is SCUS and SH. Second is the low grade squamous intraepithelial lesion, third is a high grade lesion, and then the squamous cell carcinoma. Next slide, please. Next slide, please. So it is important to look into the nucleus, because nucleus, cell type, cell structure, that this is what is our work, from where we can differentiate whether it's a normal cell or whether it is an atypical looking cell, whether it is reactive change or whether it is it's a carcinoma or neoplastic change. So what we do is, as I have told you, we compare with the size of intermediate nucleus cells. So this is our reference, as RBC is also same size of that nucleus of intermediate cells. So generally, in case of parabasal cells and metaplastic cells that we have seen, the nucleus size is increased. But it is important to know, in case of SCUS and SH or HCIL, in case of SCUS, the nucleus size is increased by 2.5 to 3 times. So we should compare, if you have an intermediate cell in the proximity, then you can compare it with the SCUS nucleus, and you can see the size is increased by 2.5 to 3 times. In case of LCL, it is increased by more than 3 times. So this is important. That's why you should be able to look into the nucleus of the intermediate cells, as it serves as a referral point, and from where we can compare different nucleus sizes. Next slide, please. So basis of chromatin, it is very important. Whatever changes that we have seen earlier, they were all benign, could be suspected as atypical cells, but what is the key factor that we have to of the chromatin? If the chromatin is fine, granular, evenly distributed, nuclear contour is maintained, so it favors the benign etiology. In case if the chromatin is coarse, clumped, as you can see, it is clumped, it is irregularly distributed, two pieces here, one here, so it is irregular distribution. And if the nuclear contour is not maintained, these are the features that favor neoplastic etiology. Next slide, please. Now, as I have told you, SCUS we have replaced 2001. SCUS was replaced by 2 categories, that is SCUS and SH. So why do we have to report SCUS? Because it denotes the cytological changes that are suggestive of squamous intraepithelial lesion, but the quantity and quality is insufficient. So there are few cells, and so because of the number of cells are come and the smear is come, so we not be able to classify it as clear-cut cell. We cannot say it's definitely a squamous epithelial lesion. So these are the categories basically where we can suggest that it could be, and it is suspected of. We should go for further investigation. Now moving towards SH, it is also cytological changes are suggestive of high-grade squamous intraepithelial lesion, but because they are very less in amount, they do not qualify the criteria that it is definitely SCIL. Next slide, please. So SCUS, the nucleus size is 2 to 3 times, as I have told you, as compared to the intermediate squamous epithelial size. And nuclear changes, you can see it could be hyperchromasia. Definitely nucleus is increased. Mild irregularity can be there, and multinucleation can be seen in case of SCUS. So these are the patterns of SCUS. That's why we have discussed those reactive changes. Atypical mature squamous cells, the metaplastic cells, if they show atypia, then it can be reported under SCUS. Parakeratosis, as I have told you earlier, if the nucleus is showing atypical changes, then we should report it under SCUS. Atrophy smear, or in case of repair, if the nucleus of the cells are showing atypia, nuclear enlargement along with uneven distribution, hyperchromatic nucleus may be there, mild irregularities or multinucleation, it should be considered as an atypical change and should be reported as SCUS. Next slide, please. So this is, you can see this nuclear size is increased. Definitely, if you can see, if consider this is an intermediate cell, then the size is increased by 2 to 3 times. As you can see, the chromatin is not very evenly distributed. It is showing dark here and some dark here and light in between. Can be minimal hyperchromasia, can be a good amount of hyperchromasia. Nuclear membrane can be smooth or can be mildly irregular. So these are the changes that we have to look for. Next slide, please. Atypical parakeratosis, that is the same as we had discussed earlier. Small keratinized cells, dense or endophilic cytoplasm, all these things will remain same. But enlarged nucleus in case of with hyperchromasia, and mild to moderate nuclear membrane irregularities. These are the features that we have to look, whether we are looking at normal parakeratosis or so that we can differentiate it from atypical parakeratosis. Next slide, please. Atypia of repair. In case of dense infection, dense inflammatory changes, we do see crowding of cells, nuclear enlargement, there can be prominent nucleoli, irregular chromatin, and loss of polarity can be there. So these cells, these atypical changes should not be confused with the normal squamous metaplastic cells that we have seen earlier, or in case of inflammation, the reactive changes that we do see in metaplastic cells. These atypia should not be confused with that. Next slide, please. As we can see, atrophy mein we generally see parabasal and basal cells. They do have high NC ratio, inflammation, and and that to granular diathesis. So these cells have nuclear enlargement, can show hyperchromasia. So these can be misdesignated as ESCAS. Sometimes nuclear enlargement, hyperchromasia, irregular chromatin, these are the features that can be worrisome. So in that case, we can actually give it as a ESCAS diagnosis. But to confirm it is an ESCAS or not associated with atrophy, what we recommend is patient should apply local estrogen treatment, should go for local estrogen treatment, that for 3 weeks, and after 3 weeks we can reevaluate the patient. We can again go for the pap smear, and if these cell changes still persist, then it could be because of the atypia. If these cell changes get normalized, the contour is maintained, then it could be because of the atrophy. Next, please. So ESCAS mimics. Abnormal cells, naked nuclei could be because of inflammation, drying artifact, or atrophy with degeneration. And generally, in case of postpartum females, we do see deciduized stroma cells. So these cells can be confused because they have obviously increased nucleus, high NC ratio, vesicular nucleus. So this can be confused with the ESCAS or atypical cells. So we have to take the history again regarding the cycle or the postpartum history or any hormone history. So these are important before reporting any pap smear. Next slide, please. So management of ESCAS. It is very important for a lab to mention their criteria of ESCAS to cell ratio, because generally sometimes because of the atypia or because of the reactive change, we do overdiagnose benign changes or reactive changes as atypical cells or ESCAS cells. So it is important whether you are diagnosing a ESCAS, it should get converted. It after biopsy, it should be like cell or not. So ESCAS to cell ratio should be 2:1 or 3:1, meaning that actually after 2 or 3 ESCAS cases that you are giving, at least after biopsy, 1 out of them is a cell, actually a high grade, actually a lesion, squamous intraepithelial lesion. So this is important to every lab should make their ESCAS cell ratio. So in case of ESCAS, repeat PAP should be done every 6 monthly, and that should be done until 2 consecutive negative tests. HPV DNA testing should be done annually, or if it is negative, then we can omit it. In case of positive findings, if ESCAS is positive, HPV is positive, then we should go for colposcopy. And after colposcopy, the biopsy should be taken from the highlighted area, and that should be go for histopathology. Next slide, please. So SH, this is basically again an atypia. The cells are highly atypical. They show moderate to high nuclear enlargement, hyperchromasia, membrane irregularity. All the features are suggestive of HCell, but because of their less in quality and quantity, we are not able to diagnose it HCell. So this type of picture is considered as SH. So you can see in this, the nuclear size is high, it is showing hyperchromasia, nuclear irregularities are there, but because of this number of cells that we are seeing are not up to the mark, or there are very less number of these type of cells, so we cannot report it as HCl. Next slide, please. Now moving towards low-grade squamous intraepithelial lesion, so which is called as ELISA. The cells can occur singly or in clusters or in sheets. So what we have to see is cytologic changes that are confined generally to the mature intermediate cells. Cells are generally increase in size, abundant in cytoplasm. Nuclear enlargement is more than 3 times. So in ESCAS we have seen nuclear enlargement is approximately 2.5 to 3 times. Definitely you cannot measure it, but you can compare it with the nucleus of intermediate cells. And in case of ELISA, the nuclear enlargement is more than 3 times. Next slide, please. Next slide, please. Nuclei are generally hyperchromatic. Sorry, the previous one. Previous one. That's it. Nuclei are generally hyperchromatic, but may be normochromatic. Nuclei show variable size. It can be normal in size, or they can show variation in the shape as well. Chromatin is uniformly distributed. It ranges from coarsely granular to smudgy. So contour of the nuclear membrane is also variable. It can be smooth. It can show slight irregularities. It can show very irregular nuclear membrane. And binucleation, multinucleation are common. Nuclei are generally absent, so they are inconspicuous if present. Next slide, please. So these are the colocytic change that I have been talking about. We have discussed regarding perinuclear halo. So why we need to differentiate it from the colocytic change, or whether it's a true halo or it's a false halo? Because colocytic change are generally associated with HPV. HPV infection are the most common cause for low-grade squamous intraepithelial lesion. So it is important for us to differentiate it from any pseudo halos. So perinuclear cavitation consisting of a broad, sharply delineated clear perinuclear zone and peripheral rim of densely stained cytoplasm. That is a characteristic viral cytopathic feature which is seen in case of HPV infection. Although it is important to know that HCl, it's not a criteria. Colocytotic change of HPV infection is not a definitive criteria for the interpretation of HCl. So even if there are features of HCl, nuclear enlargement and everything is there, and colocytic change are absent, then also you should report it as HCl. It is not mandatory always to have colocytic change or HPV change associated with HCl. Next slide, please. So this is a slide. You can see these are the normal intermediate squamous cells. This is seen in case of ESCAS, where the nuclear size as compared to this is increased by 2 to 3 times, and this is in case of ELISA, where the nuclear size compared to the intermediate cell, it is increased by more than 3 times. Now these are the cells that we have been talking about. These are the changes. You can see perinuclear cavitation or clearing. These cavitations or clearing should not be confused with pseudo halo, which you can see in case of glycogenation of intermediate cells or in case of fungal infections. So it is important to differentiate it. Next slide, please. Now we'll be seeing cytological changes associated with HPV infection. This is the perinuclear halo or the clearing, and then binucleation, multinucleation can be there. Pseudo perinuclear halo can be seen in case of trichomonal infection or candidiasis, or in case of glycogenation or navicular cells that we have seen earlier. So it is important to differentiate between these two, because if you find these colocytic change or cytopathic changes of HPV infection, it is very important to look for the ELISA cells and to go for HPV. Next slide, please. Now, problematic patterns in ELISA, keratinized squamous cells, as we have seen, atypical squamous cell with orangophilic cytoplasm, atypical parakeratosis. It can be confused. These cells show features of ELISA. However, keratinized lesion may be difficult to grade. So basically, these are also atypical cells, and these cells should not be confused with ELISA. So you can get confused because of the orangophilia, the exact nuclear picture, so you will be able to over or misdiagnose these keratinized squamous cells. Next slide, please. So So mimics of L-cell. Pseudocoellocytosis, as we have seen in case of trichomonal infection or fungal infection, or herpes cytopathic effect. Herpes infection do lead to cell changes. Earlier cell changes of herpes infection can be misinterpreted as low grade squamous intraepithelial lesion, and then changes associated with radiation. Next, please. So this is the thing that we have discussed: pseudopolycytosis, cytoplasmic perinuclear clearing without accompanying atypical nuclear features. So that should not be considered. Nuclear features are very important if you have to differentiate it from any normal looking cells. So it is very important to look into the nuclear features. So even if cytoplasmic perinuclear clearing, it should not be associated with any atypical nuclear features. Small indistinct perinuclear halos can be seen in case of trichomonas infection or in case of reactive process, and then cytoplasmic vacuolization due to glycogen, often seen in case of pregnant females, that we call it as navicular cells. So these should not be confused with the cholestatic change. Next slide, please. So this is the yellowish material that you can see. It can be seen on the light microscope as well. It is yellowish, brownish, refractile material, which is because of the deposition of glycogen, and it should not be confused with the true cholestatic change. Next slide, please. Now herpes. Early stages of herpes infection virus can be confused with low-grade cell. So basically it's a sexually transmitted infection. Patient generally presents with painful ulcer in genital region. So generally it involves the metaplastic cells as well as the endocervical cells. So there are 3 M's in the herpes infection. This is a case of full-blown herpes infection where you can see Cowdy type A bodies. So these are basically showing multinucleation, margination, and the molding. So this is the margination, the chromatin, and this is molding and this multinucleation. So if you are able to see these features, then definitely you will diagnose it as herpes infection. But the earlier stages of herpes infection can be confused with L-cell. Next slide, please. See, this is the early stages of herpes infection. You can see single ground glass type nucleus. So because of their increased nucleus size, it can be confused with L-cell. So you should be able to differentiate between two, and you should be able to ask history if there is any positive history of herpes. Next slide, please. Sometimes endocervical cells or intermediate cells, these are the endocervical cells and the intermediate cells showing herpes virus cytopathic effect with clearing of chromatin. These can be mistaken as these are the cells that can be confused as SCUS or L-cell, or if singly lying, that can be confused with high grade cells. So these should be differentiated, and whenever in doubt, we should always look for the nuclear changes. Next slide, please. Now the radiation changes that we have discussed earlier also. Radiation changes generally cause cytomegaly, increased in the NC. The nucleus is enlarged, but as well as along with nucleus, cytomegaly is also there. So overall NC ratio is lower down. Cytoplasmic vacuolation is there. Multinucleation can be there. Nuclear enlargement can be there. So these are the changes that should not be confused with the L-cell or any atypical cells. So we should take the history of radiation if we are seeing these cells, and should not jump into diagnosis of L-cell. Next slide, please. Now, H-cell. H-cell is high-grade squamous intraepithelial lesion. So these generally involve immature cells, that is parabasal-sized cells. These cells are lower than L-cell. They can be arranged in, appear singly or arranged in syncytium or in aggregates or hyperchromatic crowded groups. But nuclear atypia, that is important because HC ratio, that nuclear to cytoplasmic ratio, is markedly increased. Case of SCUS or low-grade squamous intraepithelial lesion, but it is markedly increased because cytoplasm is scant and the contour is very irregular. Nuclear membrane nuclear contour is irregular. Chromatin, it is hyperchromatin. Uneven distribution of chromatin. Coarse chromatin. Nucleoli is inconspicuous. Generally we say it's absent. And cytoplasm is moderate, scant to moderate. And most important thing, how we will differentiate it from invasive squamous cell carcinoma, it's because the background is clear. We we don't get to see generally tumor diathesis. Next slide, please. So we have included moderate dysplasia and severe dysplasia. Both SIN2 and SIN3 are included in HSIL only. The main difference that you can see is the amount of cytoplasm, as in case of severe dysplasia, less amount of cytoplasm, scanty cytoplasm with white markedly hyperchromatic nucleus and irregular nuclear membrane. Whereas in case of moderate, you can see moderate amount of cytoplasm and nucleus is definitely hyperchromatic, but the irregularity, hyperchromasia, chromatin distribution that we are seeing in moderate, SIN2, it's not that much high or that much atypical as compared to SIN3, that is severe dysplasia. Next slide, please. So these are the classical patterns of HSIL. You can see cells arranged in syncytium groups or in crowded sheets, hyperchromatic crowded sheets. So you can see cells arranged like this. So we have discussed earlier regarding endometrial cells or uterine segment. So lower uterine fragment, we used to get an entire fragment with densely packed epithelial cells along with the stromal cells. So these small cells should not be confused with single pattern or with syncytial pattern of HSIL. In case of follicular cervicitis, where we can see lymphocytes, so lymphocytes, singly lying lymphocytes should also not be confused with high grade cells. So these are the features that we need to differentiate, and then we need to look into the nuclear details as well. Next slide, please. So HSIL pattern, important point that we should note here is if the cells are arranged in group, no matter it's in syncytial pattern, it's in aggregates or in hyperchromatic crowded grouping, the loss of polarity will be there. Basically what we see is when the nuclei are arranged in parallel to each other, this is called as parallel school of fish. Then now you can see in the center, the nuclei are arranged haphazardly. They are chaotic. They are not arranged in a single line, or they are not even parallel to each other. So while reporting the HSIL, you should look for the polarity, loss of polarity as well. Next slide, please. So reasons for overcall for HSIL, what are the actually mimics of HSIL? Because HSIL can be arranged in syncytium aggregates, so it can be confused with ATP of atrophy or immature metaplastic cells, or in case of repair. As such, definitely, because we have similar type of cells, but then qualitatively and quantitatively less, call it as HSIL. And adenocarcinoma in situ, exfoliated endometrial cells, as we have seen, they are also very compactly arranged, but again you have to look to the loss of polarity and the nuclear features. Follicular cervicitis, as I have told you, lymphocytes, singly lying lymphocytes can be confused with the singly lying HSIL cells. IUCD effect, definitely, because it causes nucleomegaly, vacuolation, and then multinucleation. So these are the features that we should be able to differentiate, and that can be the mimics of HSIL as well. Next slide, please. So immature squamous metaplasia or comparison to HSIL. So the cells are small in both the cases. It can be arranged with syncytial sheets or groups. Cytoplasm is scanty, definitely. NC ratio is high. Nuclear size is high. Absence of nucleoli in both the cases. So these are the common features we can see which can be confusing. Now, based on what you have to see if you want to differentiate between immature squamous metaplastic cell or atypia to that of HSIL is the nucleus. So nuclear hyperchromasia, it will be there in HSIL and not be there in case of atrophy. Nuclear membrane irregularity will be there in case of HSIL, and loss of polarity, as I have shown you in the previous slide, that will be present in case of HSIL, not in case of immature metaplastic cells or atrophy. Next slide, please. So this is differentiating features of LSIL and HSIL. Generally, LSIL involves the mature affects the mature cells, whereas HSIL affects the immature cells. Cells can be arranged in sheets or singly. Generally, in this case of HSIL, they are arranged in syncytium pattern. Cell border is distinct in both the cases. Colocytic change that we have seen is generally associated with LSIL. So it is important to look for colocytic change when you are looking the cells of LSIL and vice versa. Nuclear size, 3 times. In case of HCl, they have not defined the nuclear size, but definitely NC ratio is markedly increased because cytoplasm is scanty. So NC ratio is markedly increased. Hyperchromasia they show marked hyperchromasia. Chromatin is granular, coarse, uneven distribution. Nuclear outline show markedly irregular nuclear contour in case of HCl. And nucleoli definitely absent in case of HCl. So these are the features that we should keep in mind while we are reporting a case. It should be considered as LCil or HCil. Next slide, please. So now we're moving towards the fourth category, that is our final category, invasive squamous cell carcinoma. So basically, invasive squamous cell carcinoma is more or less like HCl. Features are same, but we should look for the background. We should look for tumor diathesis. So tumor diathesis with HCl features and bizarre forms, we should consider invasive SCC. It can be non-keratinizing or keratinizing. Next slide, please. So non-keratinizing type, you can see macronucleoli is there. We have not seen that HCl it is not nucleoli is generally absent, but in case of squamous cell carcinoma, you can see macronucleoli, tumor diathesis. Definitely, this is dirty background. You should look for dirty background or tumor diathesis, marked nuclear irregularity, chromatin distribution is uneven, hyperchromasia can be there. So these are the features that we should look for. Next slide. Now moving towards invasive squamous cell carcinoma, that is keratinizing type. This is what we have seen. We have seen normal parakeratosis, then we have seen atypical parakeratosis that can be seen in case of SCUS, and now we are seeing keratinized squamous cell carcinoma. So it's a very characteristic appearance that we generally see in case of characterized invasive squamous cell carcinoma. That is a tadpole-like cells. So these are the tadpole-like cells. You can see this one or these are the tadpole-like cells, and they have pleomorphic, these are bizarre cells basically. They have bizarre shaped elongated keratinized tail, and they show marked nuclear pleomorphism, hyperchromasia. So if you see tadpole-like cells associated with tumor diathesis, which includes degenerated cells, cell debris, fibrin, stroma, necrosis, so you should suspect for invasive squamous cell carcinoma keratinizing. Slide, please. So, alerts in pap smear for high-grade lesion, definitely excesses of hemorrhage, pus, atypical looking naked nuclei, any past history of abnormal smear, past history of abnormal colposcopy or biopsy, or positive margins in cone biopsy. So these are the features that you should look actually before taking a pap smear. That's why we take history of any hormone history, abnormal smear, colposcopy, USG findings, so that we can correlate with the symptoms, the PV findings, as well as the radiological findings. Next slide, please. So this is just a slide to summarize. These are your normal looking intermediate cells, which we have taken as reference. And then you can see this is LCil. LCil, basically the nuclear size is increased by 2.5 to 3 times, and in case of high grade, which could be moderate dysplasia or high dysplasia, the nuclear size is increased. They have not mentioned the type, but it is increased. NC ratio is highly increased, and LCil nuclear size is increased by more than 3 times. I think that's all for the lecture.
Thank you so much, ma'am. This has been a very detailed lecture, right?
Yeah, I hope I have not wasted that much of your time.
There is no, when there is learning to be had, there is no time to be wasted. And in fact, we do have a couple of questions. In fact, my very esteemed colleague, Dr. Sharbanu Dastidar, you know, he also specializes in molecular. So in fact, he was he had a couple of questions, and he said, could you please shed light on the sensitivity with respect to HPV screening from LBC in premenopausal, postmenopausal, and HPV vaccinated subjects, right? What would be the difference in the sensitivity on this?
HPV vaccinated, generally in pre-menopausal or post-menopausal, HPV is I think around 70 to 80 to 90%. And those cases that are HPV positive, previously diagnosed or showing the HCl change in the smear, they show more than 90% positivity. So the sensitivity of LBC is very good as compared to the conventional. As we have seen, conventional smear hardly detects around 60% or 70% of the cell changes. But if we do for the liquid base, HPV sensitivity is around 90%.
And ma'am, what would be the gold standard in terms of cervical cancer screening, HPV screening?
Gold standard, I think it's the LBC. Because of the cost, we are not able to use it, especially at our center as well in Sangrur. It's a very small place. The people they are not able to pay the price, but definitely LBC because of the clear morphology, and then we can go for molecular HPV screening. So it is a better and gold standard if we go for LBC. Definitely followed by, in case of any abnormal findings, it should be followed by colposcopy along with the biopsy, because histopathology is definitely a gold standard in every malignant case. But if we look for the cytopathology and we compare it LBC and conventional, then definitely LBC is a better option.
Of course, ma'am, LBC is always promoted as the superior, but meta-analysis has shown that, and it has shown better. It has not consistently shown better analysis for CN2 plus. Like only fewer unsatisfactory smears. So, given the cost
Yes.
differential, where do you honestly draw the line on recommending LBC over a well executed, right? Because that becomes the challenge. You spent a lot of time explaining about pap smear and the importance of taking a smear correctly, because that I
True.
think, it's like your programming language. If you program correctly, you'll get the correct result. So how do
True.
you draw the
True.
line
True.
between recommending LBC over a well executed conventional smear? Does the differential come down, the quality, the difference come down between the two then in terms of results?
No, I'll not say. In case of infections like benign lesions, you can definitely see that on conventional as well. Condition, they are not no any, they are no not any obscuring material. The sample is taken on the right time. The smear is well prepared. It's well fixed. But if it is a clear-cut cancer, so that you can also see in conventional. But in case of borderline cases, that as we have seen in case of SCUS or in case of SH, where cells are small, they are quantitatively less. So it is important that you need to differentiate them. So those cases, I think we should go for LBC, and for general routine screening, we can go for conventional smear if it is properly made and properly stained.
Okay. And now I think WHO is now taking a very it's come onto the forefront, and WHO is also recommending HPV DNA as the primary screening test, of late. But
Yes,
if
yes.
HPV testing becomes a frontline, then what is the next thing for the cytopathologist? Are we doing triage only? And do you think India's infrastructure, you're in a tier 2 city like Sangrur, right? But I always believe that tier 2 cities and tier 3 cities are the future of the country. So, if the health system is good at the tier 2 level, then everything at the tier 1 level, everything falls into place any which ways, right? Most of our
True.
population lives in tier 2 and tier 3 cities. So,
True.
if we go into HPV DNA testing, how do you think India's lab infrastructure, with what you see around, are we ready for it?
We can do it. Now we do have machines for HPV testing, thanks to, you can say, it's kind of advantage of COVID as well. Because of the COVID, PCR got so much normalized. Now we have a small instrument can process like single sample or 10 samples. The costing is around 7 to 10 lakh if we go with the basic machine. But then same issue is same, that it costs us around 900 rupees or 1000 rupees to process a single test of HPV. So if we need to charge, definitely, if there is any kind of some subsidy, you can say, then maybe you can go for the HPV screening. But it is definitely costly. So I think for the tier 2 and tier 3 cities, it is better to first go for the conventional smear, because if it is well fixed and you can see the morph. In case of any doubt or in case of any lesion per speculum, if you are suspecting, or any previous history, then we should definitely go for HPV. Or those who can afford, So definitely we should go for HPV screening as per the schedule.
Ma'am, okay. Another of my colleagues had a question. He said, with HPV DNA testing becoming the primary screening method in many guidelines,
Hmm.
what do you see as the ideal role of cytology and biomarkers in improving early detection while minimizing unnecessary colposcopies?
HPV testing can be done definitely easily, but even in case of LBC, we are also preparing a smear, and it is not compulsory, as I have told earlier, कि in case every case of HPV can convert into L cell. So we have to look for the cytopathic changes. Cytological changes should be seen, so slides should be prepared, and we need to look at the morphological features. But definitely, we cannot confirmatory say that these morphological features are because of LPV. So this can be confirmed by the molecular. So it is important to do HPV testing in those cases that are showing some changes, that I feel. Obviously, from the Bethesda point of view, HPV testing should be done. It is routinely should be done, but I don't think so any of our general population is aware of that. They don't even want to get their PAP screening done, which is a basic test. So
How often should they get
that
it
is the
done?
issue.
It's an early diagnostic tool for cervical cancer, and everybody, you see it, you see the signs, you go to hospital and you see those, the posters on the wall. But if you were talking to the world at large, how often should a lady get the pap smear test done?
They don't. Generally, they come to me when they are generally postmenopausal, or they are having discharge in so long, or postmenopausal, they're having reddish discharge. So some of their RMPs must have told them ki it is reddish, it could be cancer, you need to get this test done. Then only they'll come to you. So it is important ki we are living in that scenario. We have most of our population is poor. So HPV testing is definitely ideal. But I don't think so we can afford that much. Just like TB PCR, that is given free of cost in civil hospitals. So I think maybe HPV screening can be given free of cost in civil. Then we can expect them to get HPV testing along with every pap smear. So that could be, I think, should be done to.
A policy decision, right? And
Huh.
I like the fact that you're saying it upfront, because sometimes it takes a small voice to get it raised up to a higher level. So one last question, ma'am. Uh, is circulating DNA or mRNA detection with HPV screening, and not specifically for cervical cancer, which is better? So the question,
Uh,
yeah, is the question that's come is circulating DNA or mRNA detection with respect to HPV screening, and not specifically for cervical cancer, is better? So I am not actually able to understand this question very
it's
honestly.
a basically different in the type of they're saying ki different type of PCR methods.
DNA,
So
one is reverse, one is mRNA and DNA. So you're doing it.
mRNA and DNA. So I think DNA will be a better option, but then I have to see to it. I'm not very sure regarding it, so I'll not say that this is the final answer. So
What are the biochemical tests that should be prescribed along with Pap smear for better clarity of a patient's clinical conditions?
biochemical test, it's regarding molecule biochemical test, as in what type of test we are talking about.
Is there any tests that go along with the Pap smear that that give a better correlation, that like like you say for dengue, if you're doing a testing, you say, okay, go for ELISA test along with that, check.
Along with the rapid card, yeah.
Yeah.
So it's the same. If we go for pap smear, you can go for HPV testing. They can go hand in hand in case of LBC. And for again, then you can go for USG. We do like to have USG reports along with the PV findings. So these are the basic findings that we can correlate. So testing is like conventional smear or LBC with HPV. That is the ideal thing. HPV should be done in the suspected cases, or if the client has not taken any vaccination prior. So HPV should be done along with the conventional smear, along with the pap smear.
Thank you very much, ma'am. This is one of
Thank you
the
so much.
rare webinars, which is, we've taken a lot of time, but, you've been very detailed in your approach and very patient in answering even the most mundane questions, right? Thank you so much for your time and effort, ma'am. We
Thank
look
you so
forward
much,
to
ma'am.
having another webinar with you on another subject,
Sure.
and
Thank you so much, sir.
thank you for your time. And thank you, everybody, ladies and gentlemen, for joining us today. We'll see you again on the 28th, where we have a webinar on the subject of sepsis. Thank you. Have a good day. Jai Hind.
Thank you. You too.